potassium-sparing diuretics. We didn't get through like 2 slides here, but hopefully everybody took a look at it on the slide deck. And also there were either 4 or 5 questions, the ones I mentioned, the check-home learning, that were posted. So they should be there, but basically the high points on the potassium-sparing diuretics at the very end of the last lecture, just a couple of slides. They're actually weak diuretics. They're not a very strong diuretic. You're going to use potassium-sparing diuretics more so, just like what's in the name, when you're trying to more so correct electrolyte deficiency from one of the stronger diuretics, i.e. loops and hydrochlorothiazide or hydrochlorothiazide-like. So as the name suggests, potassium-sparing, well, then you know that your K is going to stay in the system and not be excreted out in the kidney with these medications. Usually they're in combination with a loop. They're there to prevent hypokalemia, bottom line. If potassium's a problem and not volume, then you're looking at these potassium sparing. If it's volume, we already said loops, that's your biggest gun for the volume, and then followed by the thiazides. 2 distinct subclasses there on your slide. The aldosterone antagonists, spironolactone, eplerenone, and phenyrenone. You're not going to see but the first 2 usually that often, spironolactone and eplerenone. And then sodium channel blockers, there's only 2 you need to know there, amiloride and triamterene. Those are direct sodium channel blockers. They both are in the collecting duct, different mechanisms between the 2 different classes. Obviously, they have 2 different names. The aldosterone antagonists work directly on aldosterone, blocking that mineralocorticoid receptor in the collecting duct. So kind of the same things we see with ACEs and ARBs, right? If you're blocking the aldosterone-mediated, if you're blocking the receptor that's aldosterone-mediated, then you're going to prevent sodium reabsorption, potassium and hydrogen ion secretion, kind of like same things the ACE and ARBs do when they shut down the RAS system and decrease in aldosterone. So with them, you're going to, with the aldosterone antagonist, sodium loss, but maintaining potassium. Beyond diuretics is where this class and the spironolactone and the others come most into effect, because blocking that aldosterone receptor is going to reduce cardiac remodeling. So we're going to get into more of that today. Like when you have heart failure and too much aldosterone exposure, and it's kicking, and it leads to remodeling of the heart tissue itself, which is not a good thing. And so these medications help with heart failure as well as diuresis. They're a weak diuretic, as I mentioned. There is a mortality benefit in aldosterone antagonism. In heart failure, reduce ejection fraction. The sodium channel blockers obviously work differently. They block the epithelial sodium channels, you hear called the ENaC, in the collecting duct. So they're basically the second class there, reducing sodium reabsorption and indirectly reducing potassium secretion. But the second type, the sodium channel inhibitors, do not block aldosterone itself. That's the big difference between the 2 classes of the potassium-sparing diuretics. Aldosterone antagonists are going to block the hormone, aldosterone, and then the ENaC blockers will block the channel. As I mentioned, hypokalemia is what you're getting after with this, weak diuresis. And we're going to talk more about heart failure, so we won't get into that, but if the hormone blockers block aldosterone, they can also be used for secondary hyperaldosteronism, like cirrhosis, nephrotic syndrome, ascites, and then spironolactone itself has an off-label use with polycystic ovary diseases, once again because of its anti-adjuvant effects. So with spironolactone, that's what you're going to think of when you have cirrhosis, liver cirrhosis, and ascites, so fluid in the belly. Once again, because of the androgen blocking effect. Aldosterone blocking effect. Aldosterone is going to contribute to cardiac hypertrophy, and myocardial fibrosis. We'll get in deep with that in heart failure today. which leads to progressive heart failure. So blocking aldosterone is going to slow the disease process of chronic heart failure and that remodeling. So that's why this class of medication offers survival benefit, specifically the spironolactone and eplerenone and the finerenone in select patients. So these potassium-sparing diuretics in heart failure have a disease-modifying effect. Hyperkalemia, hyperkalemia, hyperkalemia. It's right in the name, right? They're potassium-sparing. So what happens in all of our medications we discuss? Too much of a good thing leads to a bad thing. So if you start retaining too much potassium, and you're going to get those arrhythmias we talked about. And oh yeah, it acts just like a lot of meds, like the ACE and ARBs. So therefore, if you use them with an ACE and ARB, the potassium-sparing diuretics, then you can get hyperkalemia. The spironolactone also has some endocrine adverse effects because of its hormone activity, gynecomastia, impotence, and menstrual irregularities. Eplerenone, more selective, fewer of those side effects. You need to know those side effects for spironolactone, those hormonal changes, those endocrine adverse effects, gynecomastia, impotence, menstrual irregularities. But obviously, if the other potassium-sparing drug, eplerenone, has less of those, so if you're having some of those bad side effects, then off the spironolactone, then you switch it to the other medication, eplerenone. So gynecomastia, might see it in questions, boards, often. They're on spironolactone, they get gynecomastia, or male gets gynecomastia, so you just switch them over to eplerenone if you still need the potassium-sparing benefit. You don't use potassium-sparing diuretics if the potassium is over 5 milliequivalents per liter. Why? They're potassium-sparing. So if you already have hyperkalemia, and then you put on a medication that's going to make you keep more potassium in your system, that's a bad thing. You don't use it in significant kidney disease. Pregnancy is contraindication with spironolactone, and high yield warning, right? ACE and ARBs, both potassium sparing. Then if you add on a potassium sparing diuretic, whether it's for diuresis or for heart failure, then you can start getting high levels of potassium, hyperkalemia, and all the side effects that we've talked about. So spironolactone will inhibit the P-glycoprotein inhibitor, and that glycoprotein inhibition alters the drug pharmacokinetics. So you can have increased absorption to medications in the brain that are affected by P-glycoprotein. That's usually more cancer drugs. And then eplerenone, once again, is a CYP3A4 metabolized medication. So any of the medications we talked about before that inhibit CYP3A4, if they're on board, we talked about clarithromycin, some antibiotics, antifungals. Don't need to know those, just know that eplerenone is also metabolized by CYP3A4. So if on other medications that also interact with that enzyme, that can be an issue with either raising or lowering the amount of those drugs that are in your system because they aren't broken down, and then you get some toxicity from them. Take 1 second to talk about angiotensin receptor neprilysin inhibitor. You see it there for drug interactions. It's something we're going to talk about a bit today. Basically, it's a combination drug. It's a ARB, specifically valsartan, and sacubitril. This medication we're going to talk about in heart failure next. It relaxes blood vessels and reduces strain on the heart, and it helps the heart to pump more effectively. Basically, you're combining an ARB with a neprilysin inhibitor to lower blood pressure and fluid retention. The reason I go into it is because with the potassium-sparing diuretics, the ARNI has the same basically side effects as an ACE or an ARB, potassium, once again. So, serum potassium can go up with interaction of any of those things there at the bottom of the slide. Or potassium supplements if you're on potassium-sparing diuretic. as with all the diuretics we've mentioned, you got to do continuous monitoring, right? You got to monitor those electrolytes, BUN, creatinine for the kidneys. There's a nice chart for you. I won't go over that. It's basically in words of everything we just discussed. And then I'm going to end this one and move into the heart failure lecture. All right, moving right into heart failure. Did that come up? Basically, high yield cardiovascular topic. It's going to be on every exam you ever see. Heart failure is going to be there. Good news is, if you've read ahead at all, we've covered most all the drugs we're going to talk about today in diuretics or in hypertension. It's just now we've got our heart failure lens on, right? That's what we're looking at this through. As I mentioned early in the lectures and last week, some medications really good for one condition, really not so good, or don't help in other conditions. So we're going to talk about heart failure today. So remember, in the discussions, mortality and morbidity. Some medications that don't offer mortality and morbidity benefits for hypertension do in heart failure treatment, and vice versa. So things that offered some morbidity and mortality decrease, the drugs used in hypertension would do so, but they may not or actually could worsen heart failure. So we're going to get into those today. So basically, I want you focusing on for what you need to take away from the heart failure lecture is survival and the symptoms, right? What are the symptoms? So what are we giving them to decrease the symptoms? And then does that medication improve survivability or morbidity, mortality? Or does that medication only help with symptoms? Which obviously, if you know much about heart failure, at this point, the symptoms can be very bad, right? So a lot of times we're just giving some of the classes of hypertensive drugs to just draw off fluid or maybe make some other changes that not necessarily help with morbidity and mortality and decreasing the advancement of heart failure, but they get the symptoms down, especially when you start talking about things like acute decompensated heart failure, where you're in the hospital and you need to be given something to get fluids off you quickly. Obviously, we're going to use a diuretic, but few of the diuretics actually change the trajectory of chronic heart failure, i.e. decreasing morbidity and mortality. We'll talk about the ones that we do. And also, we want to hit really hard drugs that we need to avoid, not just what to give in heart failure, but you don't want to worsen it, right? Because it could have some deadly consequences. So the diuretic memory jogs at the front of this lecture, it's hung for you. There's another bullet on your Canvas card. Just look at those, and it's done by each lecture. So it's hypertension, then you'll see diuretics. So the questions, check on learning with the answers are there, and the memory jogs. So in the interest of time, we'll leave those for you to take a look at. And today, not expected to be cardiologists from this lecture, right? All you need to do is understand the drug classes, how they're used in heart failures, what certain comorbidities will lend you towards maybe changing which medication you're going to use, and then which ones not to use. Always the adverse effects, contraindications, and drug interactions. So basically, on your exams, these exams in class, here in your didactic phase, end of rotation exams, when you get out and then take the pants at the end of all this, usually it's going to say which medication is most appropriate and which medication should be avoided. So you always want to answer those questions in regards to heart failure when you're choosing a medication. If you can match the mechanism with the clinical effect of what happens by giving it and the outcome from doing so, you'll pretty much have all the knowledge that you need to know about the medications that affect heart failure. All right, so this is just a roadmap for today. You can refer back to it when you're studying. It just gives you a quick snapshot of if you're deep down in the lecture slides and you're studying and you go, oh, what class was that drug? So you can always refer back to it. And then we'll talk about if they're used to treat heart failure, to decrease morbidity and mortality, decrease symptoms, if they're evidence-based or not. And then just because medications don't necessarily affect morbidity and mortality with heart failure does not mean we won't ask questions about them for symptom relief, because that can become just as important as altering the chronic progression of the disease if you're having an acute event related to your heart failure. Get into physiology, normal cardiac physiology, something that's going to be a review, right? So heart responds to an increased demand by what? It's going to increase the heart rate. That's known as chronotrophy, and also increasing contractility, ionotrophy. The heart also responds to stress by increasing preload and afterload. And we all know what preload is, but there's a definition for you again. It's basically how much blood is filling the ventricles at the end of the diastole. Basically, how much venous return is what kind of sets up preload. And then afterload is the resistance the heart's got to overcome to pump the blood out to it. And that's usually by the systemic vascular resistance, which we're going to hit our equation again in just a moment on the next slide. So a lot of the heart failure medications we're going to talk about manipulate preload, afterload, or contractility. So it's operating on those three factors. So we've talked about the blood pressure being affected by cardiac output and TPR, and then more specifically, the cardiac output is going to be determined by the heart rate and stroke volume. I'm sure you've seen that before. So this explains why that if you have medications that reduce the heart rate or improve stroke volume or reduce the peripheral resistance, they're going to affect blood pressure and cardiac workload. So these are good things acutely, right? Your body does this compensation to get more blood to the heart, have it pump harder, to get perfusion out to the end organs when there's any kind of inadequate cardiac output. However, long term, these are the exact same mechanisms that cause the further progression of heart disease with hypertrophy of the muscle, arterial wall stiffness. So these different reactions that the heart and your body is having to need to increase cardiac output because there's not enough, actually are what progress the disease and cause chronic heart failure to worsen. So the decreased cardiac output causes a compensatory mechanism, which is good, but in the long run it becomes bad. It starts to affect the heart muscle and the vasculature. So mean arterial pressure is average organ perfusion. We want it to be over 60. There's the equation there for you. I don't need you to know that, but basically if it's over 60, that's what's required to perfuse the kidneys and the brain, right? The vital end organs. So when the cardiac output now is dropping, what's happening to the blood? It's backing up. It's getting backed up and not out into the system. So if it's not leaving the body, then it's going somewhere, right? So volume's going to increase because the heart's not pumping as hard or as effectively or as quickly when there's decreased cardiac output. And then the fluid is going to cause edema, right? Because your body's not circulating it, so that's when you start to get in your extremities fluid builds up and things get really bad. Then it's going to back up into your lungs, back up onto the heart itself, and that's what's going to put you in the emergency room or the ICU and get some IV medications to get rid of the fluid and get your cardiac output increased, start pumping the blood again. So the heart failure medications that we're going to discuss, many of them are meant to maintain that perfusion, right? Keep that map up to at least 60 so we can adequately perfuse the brain and the kidneys, and then decrease cardiac workload. Because those compensatory mechanisms, if you're constantly in survival mode, the heart, compensatory mechanisms are causing it to pump harder and longer, harder and longer, harder and longer. So basically the heart failure medications are gonna be used to kind of take that workload off the heart, right? It reduces cardiac workload, or a lot of the medications we'll discuss will. It's really important in acute decompensated when you're having an acute crisis and we've got to get the workload off the heart so that you're not in cardiogenic shock. And we're going to get into those specifics here in a bit. So two major response or compensatory methods that are going to happen when your cardiac output begins to fall. We're going to fire up our old friend, the RAS system, right? And then we're going to also fire up the sympathetic nervous system, start kicking out vasopressin, epinephrine, things to clamp down the vasculature and make the heart pump harder and faster to get the perfusion that we need. And then we discussed all last week what the RAS system does when there's a sense of not enough fluid getting to the kidney. And then through that negative feedback loop, we start the old renin-angiotensin 1, angiotensin 2, and then hitting on the AT1 receptor and causing back vasoconstriction, aldosterone release, all discuss the things that we've discussed. So the sympathetic nervous system is activated and the RAS system are both activated, working in tandem when there's decreased cardiac output to get the cardiac output up and keep your MAP up and get the kidneys and the brain perfused. Short term, good stuff. That's great. Long term, remodeling, fibrosis of the heart failure gets worse and worse and worse and worse. Because when you're in heart failure chronically or an acute emergency situation, when those things continue to happen in crisis mode, that's too much of a good thing. So then you start to get some remodeling of the heart, the vessels start to get stiffer. You're going to actually have, just like any muscle, the heart is going to grow and get larger. However, when the heart gets larger and the walls get thicker, it actually is pumping less blood out every time that you have a systolic contraction. And then everything we're going to talk about today fires, blocks, or helps one of those two compensatory mechanisms to decrease the symptoms of heart failure, the backup of the fluid, decrease of the cardiac output, either rate or how hard the heart is pumping. So these medications we'll discuss all try to block one of these compensatory mechanisms, either in the sympathetic or the RAS system, depending on where the med acts. All right, so pathophys, and I've hit a little bit of it, but heart failure needs a definition: inability of the heart to pump sufficient blood to meet the demands of the body. Heart failure is basically described or categorized by the percent of ejection fraction that the heart has, basically how much fluid is pumping out with each pump of the heart. So you can have heart failure and you can still have a preserved ejection fraction. Your EF can remain above 50%. So you can have heart failure, but your ejection fraction stays high or normal, above 50%. You can have it mildly reduced. The numbers are there. That's your 41 to 49%. And then HFrEF is the one you're going to see the most that we focus on, where a lot of these drugs are going to come into play that we use for chronic heart failure, because you have an ejection fraction less than 40%. All those are going to be, you're going to get your ejection fraction a lot of times from an echocardiogram, right? Like an ultrasound of the heart. There's going to be measurements, and you can say, oh, your ejection fraction is this. And if it falls above 50 or above, okay, you still have a good ejection fraction. It's mildly reduced, takes you down to 41 to 49, and then HFrEF, so with a reduced ejection fraction, your ejection fraction is down below 40, equal or below 40%. Critically important there, because almost all the medications we're going to discuss, other than acute decompensated heart failure, they're going to be working in improving your survivability of that HFrEF category, which is the most common. And the mortality-reducing drugs we'll talk about, they're most prevalent as actors in that category, in the HFrEF, or heart failure reduced ejection fraction category. So we're going to talk a little pathophys. We won't get too deep. Try to keep it a little simple. But when your cardiac output decreases, those compensatory mechanisms we're talking about, there's a couple of them, right? So the Frank-Starling mechanism, which is basically the heart's intrinsic ability, the heart itself, to increase stroke volume and force of contraction because there's more preload. So baroreceptors and sensors on the heart are sensing that, hey, the venous return has been increased. And so we've got to compensate and increase the stroke volume and the force to get this higher volume or higher pressure in preload kicked out to our peripheral systems, right? So that can lead to ventricular hypertrophy, continual reactivation of those neurohormonal receptors, like we talked about, aldosterone. Initially, great, maintains output. Over time, wall stress, fibrosis, progressive loss of function as you get hypertrophy, and then you get a stiffening of the arterial walls from the higher increased pressure, and that's why basic modern heart failure therapy is focusing on blocking those compensatory mechanisms. And we'll talk a little bit about the Frank-Starling on the next slide. It shows preload and cardiac output, right? The preload's down in the horizontal and the cardiac output on the vertical. It's the relationship of those two. In heart failure, compared to normal, you're going to have a shift down and to the right. So what's happening here is increasing preload gets to a point where it's no longer improving cardiac output, or output effectively anyway. Instead, you start to get congestion and edema because you've got an increased preload, but your heart is not pumping enough to compensate for that preload increase. So the medications that we're going to use to affect some of that congestion and edema and decrease in contractility of the heart are going to move that Frank-Starling curve up, which means improving contractility, and left, reducing preload and afterload. That's the basis of that entire slide. Successful heart failure treatment is going to act on both, right? Help to move it up, improve contractility, and also to the left, which is decreased preload and afterload. So the heart isn't working as hard. So this is that compensatory remodeling that I was talking about. It's a key concept to understand why the heart worsens, why heart failure worsens with time. The heart's under constant stress, basically, when you're having heart failure episodes. That feedback mechanism is continually pumping. And the heart under stress, just like any muscle, is going to adapt and it's going to get bigger. You can see there on the slide, the picture on the right, how much hypertrophy is taking place in the walls of that heart. Initially, larger heart muscle, great, pumping more, but not more stroke volume, perfusing better. But as it gets bigger and bigger, it gets weaker and weaker. And also becomes a lot stiffer in the walls of the ventricle. So we say that compensatory mechanism is becoming maladaptive. It stopped being beneficial, and now it is part of the problem. So what happens with that is that heart muscle gets bigger and bigger, the walls, the area that holds the fluids are getting smaller and smaller, and the heart is pumping less effectively, and the stroke volume is decreasing, cardiac output is decreasing, and so basically your ejection fraction, as you can imagine, just gets less and less and less, and that's how you go from maintaining it in heart failure to mildly or moderately reducing ejection fraction all the way into HFrEF, where you have that ejection fraction reduced below 40%. So what we want to do is reverse or slow the remodeling, not just treat the symptoms. We want to affect morbidity and mortality, but we also have to treat the symptoms. And we'll talk about it as we go further, but the ones that are going to decrease morbidity and mortality for heart failure, the ones being the class of drugs, are going to be your ACE inhibitors, your ARBs, the ARNIs are becoming way more prevalent and prominent, taking place sometimes as first line if it can be tolerated. And we talked about those just briefly at the end of that diuretic lecture a moment ago, but we'll discuss it again. Beta blockers also decrease mortality and heart failure, and the MRAs, that class of diuretics we talked about, spironolactone, eplerenone, they also reduce remodeling, but it's only certain ones, only certain medications with some of these classes. ACEs and ARBs as a whole, ARNI as a whole, but beta blockers are only a select few, and then the MRA only one really. So vicious cycle of heart failure: decreased cardiac output, increased preload, pulmonary congestion, fluids backing up into your lungs. Increased afterload, that's that extra tension on the walls and on the arterial walls while you're getting stiffening and then thickening of the cardiac tissue, thickening of the cardiac muscle. Activating the sympathetic nervous system, as we mentioned, as a compensatory mechanism, and then also activating the RAS and getting aldosterone involved, which further leads to maladaptive changes to the heart remodeling and fibrosis. And we talked about in the beginning, it helps increase cardiac output. Long-term, unabated, continuing on this path is going to decrease cardiac output and move you into a more dangerous class of heart failure. So you can't just increase preload and contractility and think that your heart failure is going to get better. He's got 40 or she's got 40% ejection fracture, you got HFrEF, just increase contractility and decrease the afterload, and it's going to be better. No. You've got to decrease the preload, you've got to increase the contractility, but you also have to take the workload off the heart in some way to kind of reverse those compensatory mechanisms. And that's what we're going to get into, how each class that has a high recommendation in heart failure works. This is just for our visual learners. Same thing I discussed with a bunch of words on the last 3 or 4 slides, just in one picture. That's your neurohormonal activation in heart failure progression, basically your RAS system, and then your sympathetic nervous system. So now we're going to talk about pharmacotherapy, specifically in heart failure. 3 broad goals with heart failure medications. You want to block that neurohormonal activation we just spoke about. That's going to be with beta blockers, ACEs, ARBs, the ARNIs, and MRAs. So basically, the neurohormonal blockage are the ones that are going to give you increased mortality or decreased mortality and morbidity. Those are the ones that are effective at changing the disease progression in heart failure. Betas, your ACE inhibitors, your ARBs, your ARNIs, and the MRAs, which we've talked about almost all of them. Actually, we have talked briefly about all of them, and we'll just talk a little more in depth about, in heart failure, why those are Class A or Class 1 recommendations for heart failure to reduce progression of it. You also want to do increase your symptoms, right? If you're wet, dry, we've talked about that back in parasympathetic, sympathetics. It's going to come back to visit today. But basically, if you've got a lot of congestion, venous congestion, well, you want to get some of that fluid off the heart, off the lungs, out of your extremities to take the pressure off the heart, having to pump harder, and you also want to improve the hemodynamics. So we'll do that more with vasoconstrictors and diuretics, treat symptoms, and digoxin, which we'll talk about specifically what it does in hemodynamics. We want to prevent arrhythmias, because when you get heart failure and the heart's not pumping properly, then it can lead to arrhythmias. Sometimes we have to bring some drugs on board to look at just arrhythmias, but what can those be without further affecting heart failure? So we'll talk about those. The bluff is that just because a medication helps with symptoms, it does not mean it's going to reverse or impede the progression of heart failure as a chronic process or more mortality benefit. So these are the guidelines from 2022. I think I told you, just like hypertension, the smart folks, American College of Cardiology, American Heart Association, American College of Family Physicians, all those folks get together and come up with their guidelines. So I just bring this to your attention, but what I've written on top of the categories is more what you really need to know. Stage A, if you have an underlying disease state, not true heart failure yet, and then stage B, we're going to throw in the ACEs or ARBs or beta blockers, and then we'll move into the next 2 or 3 stages, and we'll talk about what ultimately an HREF or HFrEF, what we're using to treat heart failure. You can be familiar with the guidelines. There's at the end of the slide deck, you'll hear some references throughout the slide deck for the New York Heart Association. A lot of folks from American Cardiology and the AHA, American Heart Association, and ARC, American Red Cross, they refer to those New York guidelines, which are basically based on how well you can function if you have heart failure. Does it affect you being able to, exercise? Does it affect your daily activities or your activities daily, ADLs? As it gets worse and worse, as far as what you can do without having symptoms, then the numbers go higher and higher, 1 through 5. So we'll hit those. This is just an overview. Just know that there are some guidelines out there, but on the next few slides, I'm going to give you exactly kind of what your blueprint for treatment in heart failure is, which is basically what's outlined on the next 2 set of slides. But we don't really test. When I say we, the PANTS doesn't really test guidelines. They test all the things that I talked about in the beginning. I was going to talk to you about, but you won't see on there, hey, according to the 2022 guidelines, the 2025 guidelines, do this, do this. They're going to more ask you which of these medications, just like we're going to ask in your exam for this course, patient has, moderate or severe, or patient has HFrEF, choose medication, what would you not give? We're not going to have you, just like with hypertension, we're not going to say this is the blood pressure on 3 days consecutively, what stage hypertension is this? What stage hypertension is this? We're more going to go off of the parameters I gave you, and we'll probably put the stages out there just for your reference, but we'll say, hey, we'll give you, is it HFrEF? Is it mildly decreased ejection fraction, or is it normal ejection fraction, or is it acute decompensated? So you won't have to memorize these charts, is what I'm getting at, to say, oh, how should I treat it? You're going to treat it based on the guidelines that we talk about in the next slides, choosing the right medication based on what stage, but you don't have to stage. We'll give that to you at this point. There's 4 core medication classes on this slide. It's a busy slide, but we've already mentioned, right, the ACE, ARBs, or AR and I are like one bucket. The A's, and you'll see it on the next slide. So the A's kind of go together, and ACE are an ARB or an AR and I, and then the B's are the next bucket, which are beta blockers. Certain beta blockers, the ones that have evidence-based, which means every time I've said it, which means there's a lot of studies that support it as a guideline to yes. And you'll hear when we're throughout the lecture, when we're talking about what we're going to give, you'll hear GDMT, right? Guideline directed medical therapy. When you're out practicing, once you're certified as a PA, yes, you'll follow a guideline, directed medical therapy. But that's just a long acronym to say, hey, look at these 4 buckets, right? Which are the A's, ACEs, ARBs, AR and I's, and then the B's, which are beta blockers, And then we're going to talk about D's, which are diuretics, and then there's another specific medication that we'll talk about. So in the diuretics, I already kind of gave you a preview of that. That's going to be your mineralocorticoid receptor antagonist. It's going to be the diuretic of choice, at least for stopping the progression of heart failure. And then we're going to probably talk about loops and HCTZ to just get rid of fluid, symptoms only. And then we're going to talk about a new medication called SGLT2 inhibitors. And the name of that medication is another D, and you'll see why I'm giving you the ABD times 3 is what we're going to get to. 4-pillar therapy to increase mortality and morbidity and hospitalizations. So right there on stage C, your HFrEF, you'll see ABD times 3, GDMT. GDMT is what I mentioned as the guideline-directed medical therapy, which is just using the 4 pillars of the drugs, which is ABD times 3. A, once again, ACE, ARB, or ARNI, and I'm going to get into each class. We shouldn't have to spend much time on ACEs and ARBs, because we beat it up last week pretty good. And the ARNI, I gave you a little bit in the diuretic lecture a few minutes ago. And then the beta blockers, we kind of beat on them too. And then we just talk about really there's only 3 that you can use in heart failure. In diuretics, we should be on in diuretics pretty much by now. They're going to be for symptom control, except for the MRA is going to be added. So that mineralocorticoid receptor agonist, spironolactone, eplerenone, we talked about it just a few minutes ago. Those are going to be evidence-based to reduce morbidity and mortality in heart failure. And then SGLT-2 inhibitors, and we're going to talk about it. What you really are going to see on exams is a patient HFrEF that's on maybe 2 out of these 4 or 3, and they're going to say, which medicine do you also need to add to prevent or to delay morbidity and mortality? Prevent mortality, delay morbidity. So those 4 pillars are what you're going to think of. In HFrEF, if you're only on 3, then give them a 4th. If they can't tolerate 1, give them 1 from another class. And then we'll get into that for each one. And then stage D up there is way beyond our control. You're going to be in with a cardiologist, right? You're going to be seeing a cardiologist because you've got that refractory heart failure, you need a transplant or palliative care because your heart is just not functioning anymore, despite all the therapies that were brought on board. So there's our ABD times 3 again. The last, the 3, the D is not optional, but the times 3, some of those are optional. So for the A, angiotensin blockade. So if you just say the A is angiotensin blockade, we know we have 3 medications we've talked about that do that. The ARBs, the ACEs, and now the ARNIs. We discussed it briefly this afternoon, but within your diuretic lecture. And then these, the beta blockers. We talked about them for hypertension, but now we're going to talk about which ones in heart failure. And remember back our stars in hypertension treatment for ACEs and ARBs, we said those were good in heart failure. So that was just a prelude to say, hey, those medications you're going to see again in this lecture. That's why I brought them up in hypertension, so you already had an idea of which ones were useful in heart failure. And then the D is diuretics. Remember, diuretics, except for the MRAs, are symptom control. And then the MRA is going to be added. That's your spironolactone or eplerenone. And then finally, SGLT2 inhibitors. And that is the name of the most common one is on your slide there. That's why we said the D times 3. If you'll notice underlined the D there for the SGLT-2 inhibitors is dapagliflozin. So that's your other D. Diuretics, and then dapagliflozin, SGLT2 inhibitor. And then, 2 inhibitors. 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 2 as you see on the slide, as needed diuretics are the loops, thiazides, or thiazide-like. They're usually in addition to the MRAs, spironolactone and eplerenone. All right, so this is your ARNI. Sacubitril valsartan. I talked about it on the last, at the very beginning of the lecture. Valsartan we already know. An ARB, we know what it does. And we already mentioned that ARNI, which is a combination of sacubitril and valsartan called Entresto. I'm sure you've all seen hundreds of commercials while watching football. Seems like the Entresto commercial comes on all the time, but that's all it is. It's two generic medications, an ARB and then a neprilysin inhibitor. That's what the sacubitril does, inhibits neprilysin. And then obviously valsartan is the ARB. So what the neprilysin normally does is break down natriuretic peptide. So you're inhibiting that. So what's that going to do? It's going to increase peptides that promote vasodilation, sodium loss, reduce hypertrophy and fibrosis, and then the ARB component obviously is going to prevent and block angiotensin II at that AT1 receptor. So it's going to prevent the angiotensin II mediated vasoconstriction. So you can see how that combination with the sacubitril inhibited the breakdown of the natriuretic peptide is going to allow, because the natriuretic peptide is now uninhibited, it's going to increase vasodilation and sodium loss and reduce hypertrophy and fibrosis. So all the things that were bad, this combination med kind of keeps the heart from continuing to go down that pathway. And then we know how the ARB helps by preventing angiotensin II mediated effects. So ARNIs, as I mentioned, they're becoming way more popular. A lot of times they're recommended first line. They're in your A bucket. They basically have the same indications, contraindications as the ACEs and ARBs. And they're pretty much recommended now by American College of Cardiologists and the Heart Association, all those folks. Sometimes it's even first line over the ACE or the ARB if the patient can tolerate them, because they do reduce cardiovascular death, they reduce hospitalizations. There's a indication there for your NYHA class 2 to 3, sometimes all the way up to 4, HFrEF. And like I said, those classifications are at the end of the slide deck. I'm not going to, if I give you the information on the test, it's going to be additional information. I'm going to say patients in HFrEF. If we say it's, NYHA class whatever, just so you get used to seeing it, it's not going to be a distractor. I.e., you know what HFrEF is. I'm not going to say patients in HFrEF, but they're between a 2 and a 3 NYHA. No, we're going to give you a full within the limits, so you don't have to know those classifications, but they're very straightforward when you talk about moving through them. It's basically when you look at the chart, how much activity you can do without having symptoms, or are you having symptoms at rest? So basically, that's why the ARNI is considered first line. It's in your A bucket. ACE, ARBs, ARNI. A lot of folks are recommended now. A lot of folks, being the smart folks in those organizations, ARNI over an ACE or an ARB, because you don't have to worry about the side effects of the cough with the ACE. Absolute contraindications to ARNIs. If you've had angioedema with an ACE or an ARB, it's in the same kind of category, does the same things. Don't give an ARNI, or really the ARNI, because it's the only one. So angioedema in the past, don't give it. Pregnancy is a contraindication. Don't use it with an ACE. I forgot what the question came from last week, but this is a medication, ARNIs, that you have to have a washout of your ACE. 36 hours washout on an ACE before you can start your ARNI. So if you start your patient on an ACE, they develop that cough, not angioedema. If they develop the angioedema, you're not giving them these medications. But You're not switching to an ARB with angioedema, you're not switching to an ARNI, you're just leaving that A bucket empty. But if they have the cough and you want to switch them to an ARB or an ARNI, with an ARNI 36-hour washout period, you probably need to know that. Monitoring's all the same, right? Monitoring's the same for all these medications. BUN, creatinine, kidney function, obviously, potassium, always, and blood pressure. Wait 36 hours, coming off an ACE, wash out, start an ARNI. And with that, let's take 10.
I think you said switching to this one. Yes. I don't know, I honestly,
Yeah, that's why. That's from there, guys. Yeah, I'm gonna go off what I was telling you, the ABCC3, 4 categories. Maintain, mildly. As far as the decreasing ability of calories, yes. The next day is going to be the test. The third day is diarrhea again, if needed. That means for diarrhea. And then another diagnosis, third diagnosis. That's only PR. Yeah, only leukocytes. They're on. You can only do one, right? Whichever you want. At this point,
You need to get a bigger top. Don't even spend too long on our phone. Beta blockers. Probably like 3 Wi-Fi, but Bluetooth. Like this is like the same. That's how like. I remember your friend saying that like because all the same categories and because all the same categories here, we look at the same drug, like you can have attention, you have better everything, everything from theory. We're adding this something and then something that will apply to the classes. Like there's more about classes. Even like antibiotics, you can identify class by people. You kind of know like a lot about the individual drug because it's different drug in a class of different things.
So, what's happening? We're live.
Yep.
When I talked to him like the last day of the last semester, he said he was just working on it.
That's day.
For the biggest calves.
Calves?
Yeah.
Well, the short bars.
Because you're getting three. Where is it posted?
It should be posted under master something.
Oh yeah.
I doubt my counselor.
That's all he does is functional fitness.
Dude, I got my name on
Pouch on top of pouch on top of pouch. I got nothing on mine. No, my kid. All I had was my 9 and then some scissors.
Yeah. For cyber school, you do like set like a certain way. Yeah, you have 2 canteen pouches and then you put a canteen pouch in the front. Because you have to have images. So I have like 6 options. I'm taking all that shit.
I mean, in school, it's like you have to do it.
But I just have it because then I'll just keep one canteen and then I'll put like my phone in the other one and I'll put my like MVGs in the other one. Never use them. But you just keep them so you don't tie them down. I have a carabiner that sits right on this guy and I just tie it down so if I have to put them on, I just put it here and then link it back around.
So you're gonna triple C it, like bullet. I'm time commander one time. Go out there and like all I had was my 9. And then I had like the pouches on my belt for my rounds, and then just my scissors. And he was like, "What are you doing? Where's your ammo? I was like, sir, if I'm shooting, everybody else is dead.
I'm on the last stand.
I'm like, we're here to treat. If they're here to us, that means all of y'all are dead.
That is not my job. My job is not to shoot. I also have a 9.
Yeah. I was like, where's your report? Like, I didn't even draw it. What? More shit than clean. The time they didn't make it, just draw it. We just put it in plastic bags, put it on top of the Chick-fil-A. And Bliss was the same and everything.
Oh, perfect.
That was like
You standing up back there?
Yeah, he is. I need to do it because I'm about to. I was like, can I steal a piece of gum? I'm about to get
All right, let's go ahead and get started again. I'm gonna try to get through all of the heart failure stuff today. If
Me
not,
too.
we'll finish it up tomorrow before we move into angina, which is, I think, last semester, this heart failure lecture was like hypertension, 2 2-hour lectures, so we'll see if it was cut in half or close to. But I'm still pretty confident we can get you through heart failure, angina, and heme by Thursday, by the end of Thursday. That gives you all the material you can review on Tuesday, and then Wednesday you can prepare for ortho and start preparing for Pharm 2. Somebody approached me at the break. Yes, there are 3 new picture slides in what I'm briefing off of versus what you have. I'll hang those as soon as we're done with lecture today, as well as the heart failure checks on learning and memory jogs for heart failure. But I'll hang those 3 slides just for the visual folks. I think there was the end of slide information, or the end of presentation information on the New York Heart classifications. I think the ARNI that shows what the 2 different drugs within that medication does. There was one more, but I'll hang those under lectures where this file is. I'll just put another little a little space there for, and I'll put picture slides or new slides or something like that for those of you that picked up on the fact. I meant to add them. I just added those because I was like, I'm a visual learner, so hopefully those help those of you that are. All right, we're at ACEs. Shouldn't have to say anything about this slide, right? Everybody's got ACEs. We know what it does and what it does not do. And then there's your stars for which ones are useful in heart failure. And not going to see them much in the combo unless you've added in that thiazide or thiazide-like medication for heart failure after you've got the MRA on board. You're going to do the MRA always because of mortality and morbidity benefit. Continued fluid overload, then you might add in a ACTZ, which is only for the fluid. And we know what ACEs do, and we know why they're beneficial. The whole A bucket is beneficial because of decreased RAS system effects, right? Aldosterone effects, you're taking away the aldosterone effects on the remodeling and the fibrosis, and then you're also taking away the vasoconstriction effects. But you do get increased potassium, right? That's why we talk about the ACEs being combined with potassium sparing or the potassium sparing MRAs being brought on board will increase your risk for hyperkalemia, but we're gonna always monitor BU and creatinine and all of our minerals, right, our electrolytes. Looking at the potassium, looking at the calcium, looking at the sodium and magnesium, which we don't think about that often, but especially with the loops, it can cause some disruption on the heart rhythms as well when you start to drop magnesium down out. Okay, ACEs reduce preload and afterload, decrease sympathetic stimulation, net effect cardiac workload is slowed and the remodeling is slowed. ACE inhibitors improve survival. That you will be asked that, right? It's not just symptom treatment. Because of blockage of the sympathetic nervous system effects and decreasing that aldosterone, it's slowing the progression of the remodeling and the arterial stiffness that you get with aldosterone on board with too many of those compensatory actions that we briefly discussed happening when you have decreased cardiac output. So survival, ACE inhibitors, yes, all three things in the A bucket basically. That's why they're in the A bucket, is because they help with mortality and morbidity, and that's why the MRAs are in the 80 times 3, is because the MRAs did the same thing with the aldosterone effects. Some numbers for you: ACE inhibitors reduce mortality by 25%, hospitalizations by 30% in symptomatic heart failure. I don't know if that's on the slide or not, but those are pretty evidence-based big numbers that you're going to want to get your patient on an ACE or an ARB or the ARNI if they're in heart failure. They decrease dyspnea and fatigue, and they improve exercise tolerance. Back in the day, they used to say for heart failure, what do? Keep them in the bed, right? Keep their feet up, get the blood or the fluid drained off. Not so much. We want people exercise. You can still improve cardiac function with exercise even if you have heart failure. The ACE is going to slow that remodeling, whether it be from heart failure or post-MI, which is when you're going to get a lot of your heart failure patients. They have a heart attack. Some of the muscle is now dead, right? It's not contracting like it's supposed to because of an infarct. And so then they go into heart failure because with that section of the ventricle affected by the MI, now your ejection fraction is decreased because you're not using all of the heart muscle to pump the fluids for cardiac output. Unless contraindicated, every patient in HFrEF should be on an ACE, an ARB, or an ARNI. So an ACE or an equivalent, the equivalents are the two other A's, ARBs or ARNI. Unless contraindicated, pregnancy, history of angioedema on any of those three. We've kicked that horse. We don't even need to talk about it, right? Bradykinin from the ACE inhibitor. Bradykinin is not broken down, so that's why you get the cough. Angioedema, permanent contraindication for ACEs, ARBs, or ARNIs. Remember we talked about the creatinine, that 20% is acceptable. We're going to accept a 20% increase. It's a known issue or known change that's going to happen when they're put on ACEs. But we're always going to monitor creatinine, BUN, potassium, sodium, magnesium, blood pressures. An ACE and an MRA, think hyperkalemia, right? MRAs, we know, are potassium sparing diuretics. ACE, you're going to have increased potassium in your blood. So when you start seeing an ACE or an ARB and an MRA, worry about hyperkalemia. That's why we're monitoring. I just hit all this. Pregnancy, avoid We talked about the renal trifecta, right? This exact slide was brought over from the hypertension lecture. So actually, all of these are. So we've talked about the renal trifecta with an ACE, a diuretic, and an NSAID. And those prostaglandins affected by the NSAID, and then with the ACE, the NSAID effect, and a diuretic, acute renal failure risk. ARBs, once again, from the hypertension lecture. We know it, we've studied it, we know how they act. They're further down in the RAS system, right? So you're still now making your ACE, and your ACE is now cleaving that bradykinin. So you're not going to have that issue with increased bradykinin from the ACE inhibitor with an ARB. That's why there's not as much associated cough. You can still get it, but not as associated with ACE. But just think about where it happens in that ROS system cascade from the antinsinogen to the angiotensin 1 to the angiotensin 2, and where the ACE versus the ARB are acting in that ROS cascade, and then you can predict kind of the negative and the positive outcomes from it. Still going to affect the aldosterone, still going to affect the sympathetic nervous system. So the ARB is still in that first bucket. The A bucket is still going to decrease mortality and morbidity in your FREF patients. I talked about it. They work downstream. Someone had a question for me I answered last night about this figure in the bottom right. I'll spend 1 second. The AT2 receptor, the angiotensin 2 type 2 receptor, angiotensin 2 type 2 receptor. We don't know as much about it. We being like academia, the medicine, us, everyone in this room. We don't know as much about the AT2 receptor as we do the AT1. There's theory that other neuropeptides in the ROS system are affected and can bind with AT2 and keep it open, even when you have an ACE on board. Because the question was, well, if there's an ACE inhibitor on board and now you're not making angiotensin 2, are we losing the cardioprotective benefits of the AT2 type receptor in the RAS system? That's your protective arm to the right of the AT1 blocker. They stay open even in ACE, so there's other enzymes in that cascade of the ROS system. There's not just angiotensin 2, there's angiotensin 3, angiotensin 1 through 7, angiotensin 1 through 5, MRT, there's multitude of neuropeptides still being studied because, hey, if we could agonize, find an agonist for the AT2 receptor, that'd probably be really helpful to increase that protective arm of the angiotensin 2 receptor in the ROS system. But to date, there is no medication that does that. They're still trying to figure that one out. But I thought that was a good question because you're thinking through the fact that, well, with an ACE inhibitor, we don't have angiotensin 2. So what is this AT2 receptor being bound with? Something else, because it stays open even with an ACE inhibitor on board. Adverse for ARBs, just like the ACEs, right? Kalemia, hyperkalemia, potassium, we mentioned serum creatinine, mentioned it, hypotension, all the diuretics are going to give you, anything that works on the blood pressure is going to give you a possibility of hypotension. Too much of a good thing. Avoiding pregnancy, monitor potassium and renal function, caution with potassium supplements because these medications cause hyperkalemia potentially. Example, ACE, ARBs, ARNIs all share renal potassium, the same renal potassium risks. They all have the same benefit in heart failure, and they all have the same risks. So they're easy to keep the indications, contraindications separate in your different medications, A, B, D times 3. A bucket, worry about the kidney, you worry about potassium. Targeting doses, just for information only, you will not be asked targeting dosages. I mean, more than likely, you're not going to have a patient and I was talking to someone about this earlier, you're not gonna have a patient show up at your clinic, or your family clinic, or your fob, or wherever you're at, and you're gonna diagnose them with heart failure, right? And you're gonna give them these 4 medications. Normally, this is gonna be a patient, has an MI, that has heart failure, or has a lot of comorbidities, COPD, emphysema, diabetes, all the big ones, right? And then hypertension for years that then turns into possibly heart failure. So you don't really need to know the dosing. I mean, I would think that for most of us, when we get a heart failure patient, we're gonna make sure that they're okay to leave our clinic and they're leaving with a referral to a cardiologist or an internist or an ambulance ride, right? We're not gonna probably, unless you start working in a cardiologist's office or whatnot, you're probably not gonna be the one dealing out the first time the A, B, and D3 and giving those all to your patient. They're probably chronic long-term comorbidities that led them down this road, or they had a heart attack acutely. But we still have to know it because our patients that we see for other issues definitely could have heart failure or be on all these medications. We need to know those indications, contraindications, and the things that we can give them, like, oh, here's an NSAID. If your patient is on these medications and they're there to see you for their knee pain, and you give them an NSAID orally, okay, right? We talk about the renal trifecta. Could be your problem now. Acute kidney failure is a risk. So we need to know it, but we're probably not writing it. But we also need to know why the drugs are indicated and how they're used and why. Beta blockers, foundational medication, FREF. Just like in hypertension, often misunderstood, they will block the beta-1 receptor in the heart and decrease heart rate and contractility, like we talked about. The ones that are mostly useful, there's one mixed, but the ones that are mostly useful are the cardioselective beta-1 blockers. They do reduce sympathetic outflow. That's a theme in reducing the symptoms and pathophysiology, normal course for heart failure. Is blocking that sympathetic outflow so it doesn't lead down that road of hypertrophy and basically a deadly type feedback system of the cardiac repercussions that are taking place due to decreased cardiac output that do too good a job, and then we get the remodeling and the fibrosis and the continued firing of the ROS and the sympathetic nervous system. Beta blockers also reduce renin release from the kidney. Good thing in these patients. Beta blockers will initially reduce cardiac output. This is why they're misunderstood. Yes, put a beta blocker on board is going to initially do the exact opposite of what you think you're trying to do. It will initially decrease cardiac output. Long term, though, it improves survival and cardiac function by making the heart work less. And we'll get into why. They reduce mortality. That's why it's in the B bucket. It's the only thing in the B bucket. Talked about our A's. Now we're in the B's, or the ABD times 3. Beta blockers are the only thing in the B bucket. So obviously they decrease mortality. Reduce number of hospitalizations. Improve symptoms. Reduce ventricular arrhythmias. Reduce remodeling. Very important, it's dose dependent. You have to start low, go slow, and then start looking for the positive effects. You don't start them on high doses of beta blockers. Then you could shut down the heart. The higher the dose can be tolerated, the better the outcome is shown in the studies to decrease mortality. Start low, go slow, incrementally moving up until you get those beneficial effects. Caveat, your patient has to be stable and normal volume. They can't be dehydrated, overhydrated, and they have to be stable. You don't start a patient in the ER or ICU in acute decompensated heart failure on a beta blocker. They're stable when they start a beta blocker. Obviously something that decreases cardiac contractility. It decreases the rate and the rhythm of the heart. It's not going to be good in an acute stage, so it must be stable to start a beta blocker. You don't start it in acute decompensated heart failure. You don't start when they've got too much congestion. If they're volume overloaded, don't start it. Don't start it if the patient requires an ionotrope. If you're having you or someone else, whoever's running the code, has to give a medication to get the heart pumping again, to get the heart beating again, a positive ionotrope, don't start a beta blocker. It does the opposite, right? Initially, it decreases cardiac output, but long term, it improves survivability and decreased workload on the musculature. Start low, go slow. This one is a little more regular. For the beta blocker, about every 2 weeks, you'll up your dose. Target dose still is about 3 months, 3 to 4 months. Someone there, let's say 2 to 4 months. So just like the hypertensive medications, you're not just going to start on the medication and see tomorrow, oh, well, your heart failure is not progressing. This is a long game. You're playing a long game with beta blockers for heart failure. Don't start it in acute decompensation. Here's the 3. 2 beta selectives, metoprolol succinate and bisoprolol. Now there's other medication. There's another metoprolol, right? There's a tartrate. It's not one of the 3 for heart failure. It's specifically metoprolol succinate. Carvedilol, which is the only one on the list of the 3 that's non-selective beta and the alpha-1 blockade, and then bisoprolol, once again beta selective. Atenolol, metoprolol, tartrate, they don't have the same long-term effect. Others may, they haven't been studied. It's not in the recommended literature. So just know those 3, CMB, carvedilol, metoprolol, bisoprolol. HFrEF beta blocker, CMB. Really no other way to know, because you'd have to get all into the differences between those 3 than the other beta blockers, but the take-home point is you just need to know beta blocker for heart failure in your B bucket is C, M, or B, and be careful because there's metoprolol, tartrate, and succinate. It's succinate, not tartrate. Precautions, beta blockers, we talked about this last lecture or 2 lectures ago now. Diabetes, asthma. Asthma better with the cardioselective. The beta blockers that are non-selective are going to shut down the alveoli, or if someone's on a rescue inhaler or a beta agonist to help dilate the lungs because they have an air trapping disease, then you don't want to put a beta blocker on board because they're gonna antagonize each other. Don't abruptly stop beta blockers. You have to slowly titrate them off, or you can get some reflex tachycardia. Some of the beta blockers can cause lipid abnormalities. We discussed it. Adverse effect, like all medications, too much of a good thing, can give you the opposite of what you're trying to get at. You can get hypotension, you can get dizziness, bradycardia, because you don't have enough perfusion. And the bradycardia, obviously, because of the medication acting on the beta-1 receptor specific for the heart, or at least 2 of those 3. Fatigue, weakness, you're not getting enough perfusion to your brain. And then the sexual dysfunction we talked about can come along with beta blockers. We're into diuretics, transitioning to the diuretics. They do not improve mortality, only one. We already talked about it, or one class. Otherwise, these are used for symptom relief. To improve JVD, pulmonary congestion, peripheral edema, you think of it, build up the fluid, diuretics are going to help, right? Because they just have you send sodium back out to be excreted, and what do we say water does to sodium? It follows it out. Can use for exercise tolerance, to increase exercise tolerance with the diuretics because you're carrying around less fluids in your system. Cornerstone of therapy, but do not prolong life. They help with symptoms. Symptoms only, except for MRA. Should give a diuretic to all symptomatic HF patients if they have any signs of being wet, having congestion and fluid retention. Diuretics are adjunctive. They're used with your ABD times 3, but they're not a part of it. They're the D times 3 that are optional, right? They're the last thing on that slide, because if the MRAs aren't working and the SGLT1-2s and the ACE or the ARB or the ARNI, and you still have congestion, you're still wet, you still have fluid backed up, edema, pulmonary congestion, that's when you then put in the loop, the loop or the thiazide with the other medications, with your AD and D. Loops, most potent, we already talked about that. Been some question about, my statement about if they act earlier on the nephron, then they're usually more powerful. True, but in the case of the loops, yes, they're more powerful than the thiazides, even though the thiazides act a little bit further down on the nephron, anatomy-wise. But it's about the concentrations of the sodium that they are allowing to be secreted into the tubule. So just remember, loops are your strongest. They don't follow that rule. The thiazides are not going to compensate more than what the loops are functioning to pull the sodium out. Loops, the strongest, we already talked about the thiazide and thiazide-like. Thiazides are not a first line. Loops are not a first line in heart failure. Used for fluid overload. I think we mentioned this. I don't know if I hit it hard, but there is the thiazide and thiazide-like that works below the GFR that we have for our thiazides. So metolazone actually will work at 10 to 20 milliliters per minute. I think it's on your jogger slides though. But just remember, there is a thiazide or thiazide-like that works at a little lower kidney function than we said the cutoff was for the thiazides. It's the exception to the rule. Metolazone. I know it's on a few of your slides. Just want to make sure that you're tracking that all the way down to 10 to 20 milliliters per minute GFR or eGFR. Your metolazone is still kicking out sodium. Reduce fluid overload. That's what your diuretics are for. Maintain euvolemia, normal fluids. Symptomatic HF patients get it. They're adjunctive. Use it with your AB times 3 or what we said was your guideline-directed medical therapy, where we look at the ACC and AHA guidelines, those two charts. If the patient is congested, having symptoms of congestion in heart failure, yes, in acute situation, you're going to use the diuretic first to get the fluid off, but not in long-term management of your heart failure patient in FRF. But if your patient is having fluid overload, pulmonary edema, fluid on the hearts, horrible extremity edema, unable to breathe because of the fluid backing up in their lungs, or their heart's not functioning because of the fluid, yeah, we're going to give them a thiazide, or a loop. We're going to give them a diuretic that's going to act a lot faster than the MRA. The MRA helps with those aldosterone chronic changes that worsen heart failure, but is the MRIs a strong or a weak diuretic? They're a weak diuretic. Morbidity and mortality decreased by the long-term effects of the MRA. However, they are a weak diuretic. Although they are a potassium-sparing diuretic, they are further on the left of the nephron than the loop of thiazides. The loop is still your go-to choice for fast ridding the body and your system of fluids. Loop, if there's a lot of edema, you need rapid diuresis, or your renal function is impaired. Remember we said that there's that 30 as a cutoff for the thiazides. So if you have lower, we know that I just mentioned to you the one to be cautious of is thiazide or thiazide-like, that's even lower. But in chronic kidney disease, your loop is going to be still functioning even when the kidneys are not functioning that great to help you draw off the fluid and get some diuresis. So it works even below 30 when the creatine clearance is below 30 milliliters a minute. Potassium loss, right? Loop, you're going to lose a lot of those electrolytes and minerals. So need to be careful with that. And as I'm studying, I'm making sure I know which ones are going to cause me to retain potassium and get hyperkalemia, and which ones are going to help me to excrete potassium and could actually lead to hypokalemia. If you have diuretic resistance, loop's not cutting it, that's the time to add a thiazide. Even in chronic treatment, you see it as the ABD times 3, thiazides and thiazide-like are right down there with loops. So if the loops aren't doing it, then you can also add a thiazide, obviously with the monitoring that we spoke about. Low dose, we talked about it, low dose and titrate up unless it's an emergency situation. If you aren't having benefits from the loop, then you're adding another diuretic from a different class because it's a different mechanism. You're safer to add another diuretic with a different class that's acting on a different receptor, on a different enzyme, on a different hormone, than to continually just increase a loop. When you're increasing one drug incrementally, you're taking more of a chance that you're going to get the adverse effect from that medication versus if you give that medication at a low dose, start low, go slow, and you add in another medication which may have a different side effect and act on a different receptor, and those two function in unison are a safer option, kind of, joining hands and working together versus continually staying in one class. And that's what you'll see for heart failure, hypertension, diuretics, all those medications. That's why a lot of it is combination therapy, where we say, hey, these pills are combined, you take this one, you're good. Because those two things working together at a lower dose or less risk involved than just staying in one class and beating that receptor or beating that hormone or beating up wherever that drug's acting higher and higher and higher, because then you're more likely to get an adverse effect. Make sense? Remember, the NSAID use is going to decrease the efficacy of your diuretics. If things get bad enough, instead of taking an oral pill, you can always add an IV. And we talked about the different medications and all the classes that can be IV. They're in red on your FACER slides for each class. So if the oral medications, specifically now we're talking about diuretics, aren't working, sometimes it's a hospitalization and an IV to get it there faster and to cause more diuresis. So I mentioned we can increase the doses, we can go to different classes, we can go to IV. These are all if the diuretic that you're using isn't working. And then you start looking at those other actors, right? Are they on NSAIDs that are affecting the prostaglandins, or decreasing that afferent arteriole, so we're not getting the effects of our diuretics, and it's worsening kidney functions. Always monitor potassium, sodium, magnesium, calcium. We've mentioned it. Renal function, BU, and creatinine. It's the same story for all these medications, right? Adverse effects on your diuretics. Well, we've already said, if you want to get rid of fluid, sometimes you can do too much of a good thing, and you can start to get hypotension, volume status too low, orthostatic hypotension. I'm sure you guys have heard what that is. It's gravity dependent. You're laying down, you don't have enough volume, you're perfusing okay like that, at least to your brain. You stand up, BP drops out, you either go syncopal or get a lighthead or whatever the case may be. And then you'll learn, if you haven't already learned, that when we're assessing a patient, sometimes with nausea, vomiting, or anything that's causing diuresis, we'll do those orthostatics. There's a change in the systolic blood pressure when they go from lying to sitting to standing that shows us that they're having orthostasis, so a change in their volume status related to gravity dependency. Okay. So mineral corticoids, we talked about them in the last, well, it was the last lecture, but I spoke to you about them today. The aldosterone antagonist, 2 drugs that you really need to know out of this class. We're not talking about those sodium channel blockers, those 2 medications. We're just talking about the aldosterone antagonist, which is one of the 2 classes of the potassium-sparing diuretics. Just the mineral corticoid receptor agonist, spironolactone, eplerenone. I've basically told you what you needed to know about them, but they are in your ABD, they're the first D. Well, after the digifloxacin, then you're going to put in the diuretic, right? After the SGLT2. Aldosterone acts at the collecting duct, promotes sodium and water retention. We've already talked about the RAS system and what happens, and aldosterone's negative effects on the heart, on the myocardium, the fibrosis and the remodeling. So the MRAs, these 2 medications, are going to block aldosterone at the receptor. So you get a little bit of diuresis. As I said, the MRAs are weak diuretic, but you do still have the potassium retention because you're blocking aldosterone's actions. And then you're going to have a decrease in that myocardial fibrosis and remodeling. Those long-term effects of that heart we showed you a picture of getting thick and the walls getting stiff and cardiac output decreasing. And as I mentioned, the MRAs are technically a diuretic, but their use in heart failure is beyond diuresis because they're weak. They are better at reducing mortality because of their neurohormonal blockade. The numbers, all-cause mortality on MRAs for heart failure patients decreased by 30%. It's a big number. Hospitalizations by 35%. We're not going to test you on the numbers. We do expect you to know that this class of medication is the only diuretic that has morbidity and mortality benefits. You're going to add them to your AB bucket, right? You're going to add them to your ACE and your ARB and your beta blocker and your SGL2-2 inhibitor and, your ACE, ARB, and ARNI, whichever one of those 3 you choose out of the A bucket. Then your beta blocker from the B bucket and your SGLT-2 inhibitor, which is another D, and then your MRA completes those 4 pillars of ADM times 3 or GDMT, right? Guideline directed medical therapy. That's 4 pillars. You can only add them, right, if you're going to have the potassium isn't affected, right? You're not going to start adding these medication in if their potassium levels are not correct. So because the most dangerous effect is getting hyperkalemia because they are potassium-sparing diuretics. Spironolactone steroid structure, we talked about the hormonal side effects, gynecomastia. What do? You take them off spironolactone and you add them on the eplerenone. You can get impotences in males. We talked about some of the off-label uses of these medications, i.e. polycystic ovarian disease. Menstrual irregularities can be caused because they are a hormonal in structure of the MRAs. 10% for the gynecomastia. Not a huge number, but enough to be aware of it. Most dangerous effect is hyperkalemia because A bucket increases potassium in your blood, right, in your system. So we know we're adding this MRA as one of our 4 pillars to possibility of 3 medications that all help you retain potassium, or all cause you to retain potassium, maybe not help you so much if you're getting hyperkalemia above 5. If you have painful gynecomastia, switch it to the eplerenone. The ethylene is more selective on the receptor and minimal of the sex hormone side effects that we just discussed for spironolactone. But metabolized by CYP3A4. We talked about the fact that if you use other medications that are metabolized by CYP3A4 or medications that block or inhibit it, you can get too high of levels of either of those drugs if they depend on the CYP3A4 for breakdown, which means one of them that's depending on it might not get enough broken down and you get toxicity on whichever one of the drugs isn't broken down as much. And we talked about what they were, antifungals, some of the antibiotics. And some may say, why not just use the Pleurodon, right? Why even use the spironolactone? It's way more expensive. You don't use the MRAs in hyperkalemia, severe renal dysfunction, pregnancy. Less common, it may be tested. I'm not going to ask it, but you'll still see some folks out there that say peptic ulcer disease is a contraindication. It's kind of fallen out of favor. There's been a lot of studies, peptic ulcer diseases, showing that it's maybe not as affected, but you might see it. It's something to keep in the back of your mind. That active peptic ulcer disease used to be an absolute contraindication, but less commonly tested, I think, at this point. Monitor. ACE, ARB, ARNI, and MRA are those combinations, either some from the A class, and then an ARNI, or I'm sorry, the ACE, ARB, or ARNI, then the MRA, we're worried about what? Potassium. Hyperkalemia risk. And don't rule out potassium supplements. If you have somebody on any of these potassium-sparing drugs, ACE, ARB, ARNI, or an MRA, ask them about potassium supplements. Anything to decrease the risk of having hyperkalemia and arrhythmias. All right, what do we got on the left? Which of the following drugs interacts with lisinopril? I heard C, because we were just talking about it, right? Both increase potassium, raise the risk of hyperkalemia. Dangerous combination. So you just have to monitor it. Because you got your ACE, and now you're adding an MRA. What about the right-hand side? So it's an ARB. And so it's A, right? Lisinopril. ACE and ARBs together. You cannot use them together. It's an OR. We're reaching back to hypertension on this check-on. And also effective, applicable to this one as well. You don't choose two, or you don't add another A if they're already on an A bucket drug. It's an ACE and ARB or an A or an I. Or. ACE and ARBs, or ACE and RNIs, or ARBs and RNIs. Any of those combinations, side effect profile is too bad to combine them. So this is a high yield new medication. Lots of studies out there. SGLT2 inhibitors. It inhibits the sodium glucose transporter 2 in the proximal tubule of the kidney. So what does that do? Reduces the reabsorption. Reabsorption is that into my blood or into my kidney? Reabsorption into my blood. So it's going to reduce the reabsorption of glucose and sodium. Glucose now, that's the first time we're really talking much about what's happening with glucose, other than when you have decreased potassium, you might not be able to transport it across the cell membrane as well. But in this case, this is an inhibitor. This medication works on folks that, whether they have diabetes or not, it's effective. So this SGL2 does not depend on you to have diabetes or have diagnosis of prediabetes or be diabetic for it to be recommended heart failure. It works despite what your diabetes status is. So if it's going to reduce the reabsorption in your blood of glucose and sodium, where is the glucose and sodium now going? Out with the bathwater, right? It's being excreted. So a lot of osmotic diuresis with this medication. So that's, remember when we said the D times 3? This is a diuretic, basically, that we haven't discussed up until this point, except for, hey, it's in the 4 pillars. This is in addition to MRAs, but it's technically a diuretic because it's interacting with that sodium and glucose transporter and allowing us to excrete more sodium and glucose. And where does water go? Follows the sodium out, or by osmotic diuresis follows the sodium out. I'm sorry, the glucose out. Independent of diabetes status, SGLT2s reduce heart failure hospitalizations, cardiovascular mortality, and it's good for all classes of heart failure. All classes of heart failure. HFrEF. Heart failure with retained ejection fraction, heart failure with reduced ejection fraction, heart failure with mild loss of ejection fraction, and without diabetes, or with diabetes. If you see a patient on an exam in heart failure, not on SGLT2 inhibitor, that's the one you need to start looking at. Do we need to add on? Why? Think about the pillars. Just like the beta blockers, it's sitting there all by itself. And the MRA is sitting there all by itself. So the D, we talked about the generic name. That's where the D comes from. The D that ends with a X and the INN, right? It's on your slide. SGLT-2, and that's where one of the D's of the D times 3 is coming into play. Improve outcomes despite ejection fraction ranges. I know that. There's only 2 right there, the dapagliflozin and the empagliflozin. Once again, these have renal function indicators. They're about the same as the ACTZ or hydrochlorothiazide-like, around, they stop really functioning at about that 30 milliliters per minute. Like all medications, you're going to check GFR, kidney function, potassium, magnesium, BUN, creatinine before you start this medication. Common effects, adverse effects, well, increase urination because you're peeing out sugar and salt, and water's following it out. So obviously, you're going to be urinating more. You can get mild hypotension, weight loss. I'm sure you've heard of that on some of these medications. Kind of a unique side effect is some infection risks that are listed there. Genital fungal infections, especially in women, and UTIs. There's been some studies that shown a increase in bladder cancer from the DAPA. So basically, if your patient has active bladder cancer, I would not put them on this medication. Genital infections, weight loss with heart failure, and their own an SGLT-2 inhibitor, that's your culprit. Kind of stands out. We haven't really talked about anything else that does those things. All right, so this is a good stopping point. We're going to hit vasodilators tomorrow. There's just a couple of them that we'll talk about, but we got through the meat of it, and then we'll be able to move into angina. We can get through that pretty quickly. So I think we definitely didn't need the 4 hours, and I don't think we'll need more than like 10 or 15 minutes tomorrow to get through this, the highlights of what's remaining of the slide deck. I will update tonight when I'm done here. I will put in the slides of the pictures that I added, and then I'll hang the check on learnings and the memory jog